Good morning, everyone. We welcome you all to this panel discussion today. I hope that you remember me. I am Govind, Dr. Govind Bansal, working as DAPCU coordinator with National Technical Support Unit at NACO. We welcome you all to this panel discussion. The theme for this panel discussion today is strengthening DAPCU's engagement in TB HIV collaborative activities. The participants in today's discussion, we have participants from the DAPCUs, all 188 DAPCUs. Then we have representation from the ART Center, from SACS officials, JDCST. Then we have officers who are looking after the DAPCUs, that is DAPCU nodal officers. We have representation from the DNRT, regional coordinators for the DNRT who have been mentoring the DAPCU staff for quite a long time. And welcome all of you. For this panel discussion, we have with us today two eminent speakers who are the subject experts in their own field. We have Dr. B.B. Revari, who is a National Program Officer with CST Division at NACO. We welcome you, sir.
Good morning.
We have Dr. Rajesh Deshmukh, who is the Program Officer for HIV/TB activities at NACO. We welcome
Good
you.
morning.
You all are aware that the TB HIV collaborative activities are jointly implemented by the NACP and the Central TB Division. This is done to provide the TB treatment and care services to all the TB HIV patients. At the same time, you are aware that the District AIDS Prevention and Control Units, that is DAPCUs, they were established in NACP 3 as a decentralized model to monitor the activities of HIV at the district level. These were established in 22 states in 189 districts across the country. Out of so many activities and the major responsibilities at the district level, one of the major responsibilities of DAPCU is to look after the TB HIV collaboration activities at the district level. In that, they are supposed to coordinate with the DTOs, district tuberculosis officer, and also to facilitate the conduct of DCC, that is district coordination committee meetings on a quarterly basis. Not only that, they are also supposed to look after the sharing of line list and the validation of those line lists amongst DMCs, ICTCs, and the ART centers on a monthly basis. This is one of the major responsibilities. Looking at all these responsibilities, we thought that it's important to have a discussion, giving them an update, giving all the DEPCUs an update on the RNTCP program, and so that they will be aware about the latest developments and they will be in a better position to monitor such activities at the district level. With this background, I invite Dr. Deshmukh to share some thoughts on the status of HIV/TB epidemic in the country and the responses from the government of India at different levels. Dr. Deshmukh.
Thank you, uh, Dr. Govind. First of all, you are all aware that in people living with HIV, and this is the commonest cause of mortality among people living with HIV. If you see the global scenario, India has highest number of second highest number of TB HIV cases after South Africa, and although the prevalence of TB among at the national level is 5%, but we have certain pockets in India where we have very high prevalence, especially in South. If you see, there are certain districts in South where the mortality of TB and HIV co-infected cases is very high, and it raises important challenges for the program managers to address those challenges. Even if you see that the latest HSS data from NACO, it shows that the states which were earlier low prevalent states for the prevalence of HIV among ANCs are now showing rising trends, especially states like Delhi, Odisha, Chhattisgarh, and these states, as you all know, that there is a huge out migration from these states to some of the very high prevalent states for HIV, like the states in South. And secondly, there is an important thing that these north states, they have high burden of TB. So such instances and such challenges, they are now increasing the burden of TB and HIV in the country. Moreover, we are seeing that the drug-resistant TB challenge, the challenge of MDR, multi-drug resistant TB, as well as XDR, the extensive drug-resistant TB, has also fueled the epidemic of TB and HIV in the country, and it is posing a big problem in some of the metros in the country. If you ask me regarding the government of India's response to this situation, government of India has started TB HIV collaborative activities in coordination with revised National TB Control Program way back in 2001, and now it's almost expanded to nationwide coverage in 2012. We have actually some policy guidelines in the form of the National Framework for TB HIV Collaborative Activities, latest updated in 2013, which is in line with the WHO TB HIV collaborative activities defined in 2009 and 2012. Some of the important aspect of this national framework, I would like to highlight. One is the coordination mechanisms in the country. We have coordination mechanisms at different levels, like the national level, state level, and district level. At the state level, at the national level, we have the National TB HIV Coordination Committee and the National Technical Working Group for TB HIV collaborative activities. Similarly, we have State TB HIV Coordination Committee chaired by Health Secretary, and also the State Technical Working Group. Uh, the most important thing, and for the audience also, we have a very good mechanism of district coordination committee, and also we have mechanism for review of TB HIV collaborative activities monthly at the district level. Uh, you are briefed by Dr. Govind that district DAPCUs, how important their role is in district coordination committee. You are aware that district coordination committees are backbone at the district level to address many of the policy changes and the situations, challenges at the district level. There is an important element for TB HIV collaborative activities in India, the three I's which are defined clearly in the national framework. The first I is the intensified TB case finding at different levels, HIV care settings, and the second I is isoniazid preventive therapy, which is IPT, and the third most important is the infection control at HIV and TB care settings. So these three I's are clearly defined in the national framework as per the WHO policy guidelines. Uh, Regarding the intensified TB case finding at the ICTCs, the FICTCs, the ART centers, the link ART centers, and even the targeted intervention sites, we have actually sent out guidance documents. We have in place the 10-point counseling tool, which facilitates the intensified case finding using the 4 symptom complex, that is cough, fever, weight loss, and night sweat. So these are important uh, points which we emphasize in the intensified case finding. We have actually uh, standardized reporting and recording mechanism at the various levels. Recently, we have also gone electronically in the form of Nikshay, as well as we have inbuilt system from NACO, SIMS, and other formats, electronic formats, to capture the information on intensified case finding activities. If you ask me that how these are changed in the present scenario, I would like to quote some of the recent initiatives which we have taken to actually intensify the TB case finding among the PLHIVs. We have in place in some of the centers using rapid diagnostic, very well known as cartridge based nucleic acid amplification test, CBNAT, at more than 100 sites in India, out of which we have some 76 plus sites which are in the same facility where we have ART centers. So these equipments have the capacity to diagnose TB with, as well as rifampicin resistance within 90 minutes. So this has drastically changed the case finding activities. Early diagnosis is very critical for PLHIV in terms of TB diagnosis, and then initiation of treatment at this level. Second important thing which is actually in the pilot form and the government has even approved that the National Technical Working Group and the subcommittee on daily regimen for TB HIV patients, they have approved the daily regimen for TB HIV collaborative for co-infected patients. In this, actually, we have started with 5 high burden states, wherein we have started an intensified TB case finding and innovative diagnostic using CBNAT plus daily regimen pilot project in 30 ERT centers. So we have actually an innovative mechanism in this one where we are actually tracking the patient treatment adherence also. So this daily regimen FDC has been devised with a mechanism of actually an number which is there at the back of the strip where the patients, his relatives or the dot provider can give actually a missed call to track the adherence, and in this mechanism we are able to some adherence levels in the existing pilots. So this HIV TB daily regimen up to other parts as soon as the drugs are available. And third important thing which I have quoted, that isoniazid preventive therapy, which will be rolled out shortly after the availability of the drugs. Before that, we'll have some trainings for each and every staff regarding this one. And now we are actually from NACO side as well as from Central TB Division emphasizing on the infection control activities to prevent TB infection for those PLHIVs who are attending the HIV care setting. So already some of the initiatives have been taken in this regard, and training and all things have been completed. So broadly, I have summarized these important activities which are laid down there in the national framework. If you visit the website of NACO, you will get all the standardized report as well as all the details on the NACO website regarding the national framework for TB HIV collaborative activities. If you see the strength of our TB HIV collaborative activities is the linkages to care and support and treatment services. So we have very good linkage mechanism in terms of linkage to cotrimoxazole preventive therapy as well as ART. Dr. Revari sir is with us to elaborate on these linkages, and I I think these are in short the responses of government to address this dual epidemic.
Thank you, Dr. Deshmukh. There, no doubt, these are the different mechanisms at the different levels that you have explained to the audiences. But there are certain challenges also, which we would like to, after this discussion, we would like to come back to you. There are a few questions from the participants also. We'll come back to you on this. Now, after the identification of the HIV/TB patient,
Do I need to repeat or it was okay? I have to repeat the same thing? Okay, I think I'm told the message has not gone due to some sound issues. I was saying that India has got second largest burden of tuberculosis in the world and third largest burden of people living with HIV in the world. And 42,000 HIV TB co-infected persons die every year in India, which is 10% of total HIV TB deaths across the globe. So it is very important that these HIV TB mechanisms which have been put into place and are working need to be more efficient, need to be more efficiently monitored, and the linkages need to be strengthened because the mechanism that has been developed, has been field tested, is working well, but we need to improve it to further reduce these deaths by detecting more people with TB who has got HIV and more people HIV who may have TB. So that is the linkage that we are talking about. And Dr. Deshmukh clearly told about three I's, that is early intensified case finding, isoniazid preventive therapy, airborne infection control, and there is a fourth eye to it, that is early initiation of ART. As you know, NACO has moved now to 350, but for TB patient, all patients with TB, whether it be pulmonary TB or extrapulmonary tuberculosis, ever since 2011, they are being provided ART irrespective of CD4 count, and maybe in near future we'll move to 500 for the general population also. Coming to linkages, you know the mechanism is very clear. There are two-way mechanism. All TB sites, all patients who have TB or suspected with TB are offered HIV testing and referred to a ICTC. That referral may lead to some of the losses, and there is a mechanism now that all DMC designated microscopic centers will be provided with HIV testing facilities. Almost 70% of them are now co-located, and almost all sites will have testing facility so that the loss in patient going from one facility to another is actually plugged. That is one. Second is coming to ART centers. All patients who come to ART center on every visit must be screened with 4 symptom screen that Dr. Deshmukh very clearly elaborated. It is the responsibility of everyone. Though it is done by the care coordinator at the beginning, it should be done by the staff nurse, should be done by the medical officer and counselor. So everybody should suspect TB if they have got any of these 4 symptoms and fast track these patients for TB testing. It is very important that these patients go for TB testing at designated RNTCP site. Now that is the mechanism we want to strengthen through you, that you monitor this mechanism. Mechanism is that there is a HIV TB line list. Staff nurse at ART center is basically the focal point for this activity, and all patients who are suspected for TB should be entered into this line list. This line list has got specified number of columns, and first 10 columns are to be filled by the staff nurse, and this line list is to be shared to basically with the STS at that site. Now, once these patients reach the site and are tested for TB and found to have TB or not, their TB status is sent back to the ART center, and this line list exchange happens in the monthly meeting, which is coordinated by DAPCU. Why I am emphasizing is that whenever there is a meeting of DAPCU, which is every month, you have to ensure that this line list exchange happens. Line list is completed. We have seen that many times there is exchange of line list, but some columns on the either side are missing, which are not, information is not provided. So that leads to delay in the diagnosis of TB or in the initiation of ART for these patients. So both components have to be seen, whether TB has been diagnosed, ART has been started. The guidelines say it should be started within 2 weeks to 2 months of starting ATT by the time patient is stabilized. And it is important for you also to monitor that all those patients who have been started on ATT have been initiated. This responsibility is fixed for ART medical officer also, staff nurse also. But when you oversee the mechanism, when you are having this meeting with the both sides, it is important to see that this gap is basically filled in. Another gap that we have observed during our linkage or at the ART site is provision of CPT. You know, all patients with TB have to be provided with cotrimazole preventive therapy. This is normally now provided at ART center whenever the person reaches ART center. During field observation, we have seen that this may not be very regularly provided at some sites. So DAPCU has to ensure. How he can ensure? There are many ways this CPT is supplied. One of the mechanisms is that SACS procures this from the OI fund, which are released by NACO, and provides them to all ART centers and the TB sites. Now issue is sometimes these run out of stock, then it is provided through the hospital pharmacy in many places. But again, you have to ensure that patients are not only prescribed, they are dispensed and they get it. We have observed a gap that many times prescribed, they go to hospital pharmacy, but they get it for 7 days. Though there is a standing order that all patients under the program should it get for 1 month from the hospital pharmacy also. But many times it is not provided. So that leads to a gap in between. Because CPT has got an independent role in preventing mortality in these patients in addition to prevention by ART and prevention by the TB treatment. Second tool that is there at ART center is basically HIV TB register. Basically, all patients who are found to be positive um, HIV and have got TB are entered in this register. And this register, though it is maintained at ART center, the staff nurse is supposed to bring this register also to the DAPCU meeting to see that all these patients have a baseline CD4 count, have got a date of ART initiation, and have got TB outcome also entered when the TB treatment is completed. So completion of record is not for record keeping, but for ensuring that the treatments are given as per guidelines. Secondly, what we have seen regarding airborne infection control is there is clear guideline that all ART center at the beginning should have a mask which patient should wear when they enter. It is not for the staff. It is for the patients when they enter and have got cough should wear that mask, and these patients should be fast tracked. Again, each ART center is supposed to put a notice that these patients with cough, children and pregnant women are supposed to be fast tracked. Means other patients should know that there is a mechanism and they are not going out of turn because they may object. But during one of the recent visit during JMM, we saw that the patient were given mask, but they were sitting in the general queue waiting for their turn. So that increases the chances of this patient getting exposed to TB or other patient who have got immune deficiency, and these patient may be positive for tuberculosis and may be transmitting the infection. So there would be other measures for airborne infection control, which will include changes in the design, changes in the structure, changes in the airflow, some kind of filters and UV lamps, which will come in through this project that we have got through new funding model. But these are the basic minimum things that we can do is the fast tracking. And your meeting as DAPCO, you have to visit the facilities, and when you visit the facility, you have to see that these things do not remain on paper and these are actually implemented. Lastly, Dr. Deshmukh has told you about some newer initiatives. Newer initiatives are daily tuberculosis treatment, provision of ATT by the ART medical officers, gene expert. These things are expanding, but presently these newer initiatives are at 30 sites only. So that was more for information and for those DAPCUs who are involved at these 30 sites, that they should ensure that all components, there are 10 components of this which have been sent clearly in the guideline, should be implemented at these sites, because experience from these sites will lead to expansion of these to other sites. So DAPCUs as field supervisors and facilitators have got a big role in actually scaling up these HIV TB activities. You know that 73% of TB patients know their status, HIV status. Why not 100%? Every TB patient should know their HIV status. That is where your role comes in, that ensuring that these coordination mechanisms, referral mechanisms, and the losses at the various stages of referral are actually plugged in.
Thank you, Dr. Rewari. He very rightly elaborated on the gaps at the implementation level. And not only those gaps are there, but he has also suggested the solutions for that, which is more important. Many times it happens that we are aware about the gaps, but we don't know how to correct them and what are the remedial actions for this. So those are very important things. And sir, just to let you know, the panel, that before this panel discussion, we sent a communication to all the DAPCOs and we asked them, right, what are the challenges that they face at the district level. And few of them, they have responded to us sending their queries and the challenges at the district level. So I would like to put up a few of those challenges.
I think that was a very good initiative that you get the questions, and as a part of this, I can see some people will be typing out their questions also. Though we won't be able to answer them right away because we can't see those questions right now, it's at a distance. But we will again compile them and send it through email, and that all the answers will be provided. But we can take up the questions that we have received.
Sir, when you were saying few of the gaps and like few of the best practices also, I just recalled one of the initiatives at the Bhiwani district, sir. There what happened, in the Bhiwani district in Haryana, the DACO instructed all the TB reports will be collected from the ICTC counselor, and thereby he created a single window mechanism, ensuring that every individual who is tested for for TB is also counseled and tested for the HIV. So just wanted to know, like, whether can we implement such initiatives in other districts also.
So, Bhivani, as actually here the question which was there has mentioned that there is a single window for reporting. through an counselor. And actually, we'll have to see that the standardized mechanism of recording and reporting is followed in the district before scaling up such initiatives, because data management is the most critical issue which is related at the district level. And so when we go up and up to receive the data, we'll see that there is a discrepancy in data for TB as well as HIV. So TB department and HIV department are trying hard to uh, collect the information which is correct, complete, and compiled properly. So there the role of single reporting system, but then we'll have to actually see that some IT based platform which is single platform with reporting of TB and HIV data which is correct, complete, and uh, consolidated data at the district level. That is important to scale up.
Dr. Deshmukh, is this a different mechanism from existing mechanism?
This is definitely a
Yeah, so
different. We'll
but
have to actually see these
and this
things.
is not IT based. We have a very
This is
good
not
system,
IT.
Nikshay,
Yeah,
in our
yeah.
HIV, TB, this thing. So going back to a paper based
Paper-based
mechanism
system.
and collection
That is why.
mechanism, would you like to expand that?
That's what we will have to see actually, because there are errors in transcription while we are having paper based systems. We are actually having some very good IT systems in place in RNTCP which can be very well supportive to TB mechanisms at the district, below district level. Even we can uh, inbuilt some of the systems wherein we have linkage for TB HIV data between NACP and RNTCP. That is what we are aiming for, as Dr. Revari sir has mentioned. So before scaling up such activities, I think we'll have to see how much this uh, is giving yield in form of correctness and completeness of the data.
Thank you. We'll take on to the next thing. We got some report that the GSEX, Gujarat SEX, they've been providing certain funds to DAPCUs for sensitizing ASHAs and Anganwadi workers so that they can, for the screening and also dispensing the dots to the TB patients. Not only in Gujarat, this practice is happening in Assam also. So, is it again the standard practice or is it a niche area still? And can we expand this to other states also?
So, RNTCP has a very good strength in the program that it has decentralized up to the village level. So, ASHA's involvement and Anganwadi worker involvement before the ASHAs were there in the program. Uh, and this mechanism is already in place since years, where the ASHA and Anganwadi workers are sensitized, and they are also actually delivering services in the form of dot services. Government of India provides honorarium to health work, these community level health workers. Not even ASHA Anganwadi, but there are many social workers who are working as dot providers, and this is already there in the program. So if some new practices are there, that can be actually considered as best practice. But this, I think, it's good that we are sensitizing them. We need their involvement in TB HIV coagulated patients in the form of actually some sort of adherence to the TB and HIV treatment, where the ASHAs and Anganwadi workers can very well sensitize, motivate the patient, counsel the patient to adhere to TB and HIV treatment. So that, I think, is very important initiative.
We saw this in AP also when we went to district Vijayanagaram and we went to remote areas and we saw ASHA and Anganwadi workers doing this quite well. Rather contrary to my belief that it is difficult, they were doing it quite well and acceptability was very high. I've got a feedback from the organizer that many participants are not able to hear us. We will continue with this. Try to speak loudly, but then we will send out you the link also, which you can hear the later also.
Okay, Dr. Deshmukh, during your when you were speaking about the HIV/TB activities, you also mentioned that it's important that all the DMCs they should have the HIV testing facilities. A few of the states they have really done well, like Maharashtra, they have been faring well, but there are few states who are still lagging behind. So, with respect to this, can we set a timeline for this, or can we take some action so that all the DMCs they have these testing facilities? So I'd like to have your views on this.
This is very good question, and we will address this later on in a summarized form. But definitely, co-location doesn't mean exactly that it should be side by side within the same facility. If we have ICTCs or FICTCs and the TB diagnostic facility, we actually will be able to reduce the missed number of cases. So there are states where the co-location rates are very high, like Andhra Pradesh and Tamil Nadu, where if you see the co-location is up to a tune of 92%, 93%, and then the testing rates have significantly improved in these states, because they have these facilities within the same health system. So there is a linkage loss, and number of missed cases are reduced. So our main actually uh, priority is to have co-located facilities. Co-located means within the same facilities we have both the testing and functional co-location, even multitasking by the same LT. So definitely DAPCUs which are placed more in those areas where the co-location is less. Particularly, I would like to mention some of the states where there are increasing trends. The co-location status remains less than 40, 50 percent. There, DAPCUs can contribute in coordination, district coordination mechanisms, and district collector is a very in his advocacy. Actually, you can scale up the systems in coordination with NHM. So.
Dr. Deshmukh, if I am not wrong, this is NACP4 target. When we talk of timeline, by NACP4 end, we have to have all DMCs should have HIV testing facility within them. That is the target. But I would like to have another practical point for the DEPCOs here. When we say they are co-located, it is only FICTC, means they have only a screening test. So all those who are found positive with the screening test have to be referred to a standalone ICTC, and that is again a potential area of loss, because within the same facility you test and find positive, then you refer, because you don't have three tests at these centers, DMCs. So you have to ensure that those who are found positive with the screening, they are not given a report, they are only referred to a standalone ICTC. You should ensure that this linkage loss is again prevent. But DAPCU's role in this whole is to prevent losses. So this is another area where you have to focus.
Just to add on to this thing, apart from the DCC, District Coordination Committee meeting, there is another meeting, DAPCC, that is District AIDS Prevention and Control Committee, which is again chaired by the District Collector, and it happens on a quarterly basis. So, if there are any administrative hurdles with respect to the creation of such facilities, then those issues can be raised in such meetings. These are a very good platform to utilize these platforms is very much important at the district level. Coming on to the next thing, a few of the DAPCOs they share that the monthly reports, we talk about the sharing of the line list and the validation also at the monthly level. Uh, I respect that we have been emphasizing on this, but there are certain challenges at the district level in terms of sharing of this list. Many times these lists are not shared on a monthly basis and they come on a quarterly basis. So it becomes very difficult for them to actually validate, okay, how many patients actually got tested and how many of them were identified as TB. So like how we can bridge this gap in terms of having this list on a monthly basis. Many times in certain districts, I won't say that all the districts, but there are certain districts wherein such challenges are there.
Although, see, when we understand the question, we will see that there are two aspects in this. One is actually the question focuses on quarterly reporting of RNTCP, and because of that, some of the DAPQs they are questioning that we are not able to get the information on monthly basis. But here the point is clear that RNTCP reports quarterly, but there are monthly programmatic management reports. Programmatic management reports in RNTCP, even you can get the information on monthly basis reports are sent to different levels, but then you can get the information on how many of the patients are registered and how many of them are tested for HIV during this month. There are definitely mechanisms in place, but they are not happening actually. So monthly TB HIV meetings, if they are happening in those districts where they are regularly happening, they can easily get the information from the corresponding counterparts. Even STS, STLS, they are sharing the information uh, in those districts. But what we saw in the recent reviews at the national level and at the regional level also, there are many districts where the coordination meetings as well as the monthly meetings are not happening regularly. So if we have meetings regularly, there will be definitely exchange of data, and actually even though the reporting systems are defined, we can share the information within us.
Just to add to this, this information is required by DAPCU. The question is how DAPCU will get the information on TB cases detected in a month in the district. So this can easily be obtained from the DTO. DTO can provide this information to them in the monthly meeting.
Many times there is some gaps in terms of getting this information.
Yeah, but as he said, it is a quarterly report which is sent higher up. But the report is prepared on a monthly basis. They may be preparing a report for sharing on quarterly basis. Information is available, in fact, on a daily basis, and monthly information can be obtained as a baseline. The other question basically, how will DAPCU know the ATT completion and follow up? Whether the person has completed ATD, or missed, or defaulter, and what is the outcome. You know, as I said, there is a HIV TB line list and then there is a HIV TB register. All those persons who are on ATT and ART are entered in HIV TB register, which lists all these information, but this information has to come from STS. This because person is taking ATT, but he is following up at ART center also every month. So whenever his TB treatment is completed and outcome is declared, in his TB card it is recorded. And when he comes to ART center, naturally the ART center staff nurse has to ask and enter that into the HIV TB register. So once it is entered in the register, basically this information can be obtained. And the role of DAPCO will be looking up again at the column in the HIV TB register whether this outcome has been filled or not.
Same goes with one of the other outcomes. Death is also one of the outcome which is entered in that register. So few of the DAPCOs they have been asking that they don't get the report on the deaths. I would suggest that they should also again look into the register whether it has been filled it or not. If it is not, then
Death becomes slightly different because TB treatment will not be able to give the outcome because the person has stopped coming to ART. ART has got a LFU list, and as soon as he become miss, he has not taken up his treatment. His line name is shared with the outreach worker of care and support center. Basically, most of the deaths will be reported through that mechanism, through outreach worker of care and support center, that these patients were followed up whether they were miss or LFU, and it was reported that they have died. So it comes mainly from the field visit by outreach worker, the information more about death.
Uh, there is one more question from one of the DAPCOs in Delhi. Somehow, we believe that there is some difference in terms of the functioning in the metro cities like Delhi, Mumbai, Chennai, Ahmedabad, and in other districts. Like I'll quote an example from the Delhi. There are four DAPCOs in Delhi who have been looking after 11 districts, 11 revenue districts in Delhi. Now there are 25 chest clinics and 25 DTOs, and it becomes very difficult for them to actually get this information. So, do we have any separate intervention or any separate policy for the metro cities, or is it the same with other districts as well?
I think metro cities have this challenge everywhere. It's not only Delhi, other metropolitan cities. And one of the reason is many of the persons come from outside and they get tested and then they go back to their state. Some of the patients are hospitalized whereby they know status, they are discharged and they are not followed up at many places. There is a mechanism of sharing of line list of patient loss to follow up interstate, but that is very difficult to coordinate. One state tracking patients, other state is very, very difficult. But basically, this issue can be resolved in the meeting with the state TB officer. In STO meeting, basically all DTOs are available and ART centers are available. So in that meeting, in STO's meeting, this issue can be resolved.
In fact, I was going to answer the same thing, because in major of the metros we have decentralized mechanism of reporting units in RNTCP. So Mumbai has 24 districts, Delhi has different reporting units. In such situations, the state TB officer who calls the district TB officer, or the city TB officer who calls other district TB officers or the reporting units, that meeting is also important, where the transfer line list is also shared. So RNTCP has a mechanism of transfer in, transfer out, where the details of the transfer patients are shared with the different states, with the different DTOs through an online mechanism. So definitely IT based platforms have reduced the information gap related to TB transfer out of treatment, as well as outcomes also. So we get the information on outcomes also. Related to coordination, it's very good that in addition to the reporting units and the district TB officers, you also emphasize on coordinating with the state TB officer in metros, Delhi, in city TB officers in Chennai or Mumbai. So there you will get the information along with.
So that means that DAPCUs can also participate in the meetings, in these meetings, and they can interact with the DTOs. Okay, one more question, which has again come from the DAPCU district in Delhi. They have been asking, I'll just read out the question, whether TB symptomatic clients who are not diagnosed as TB be offered HIV counseling and testing services.
There was a study done by CTD in which it was shown that even among TB suspects, the HIV positivity may be in the same range as among TB clients, that is around 5%. So it was decided that in A and B category districts, TB suspects who are not diagnosed as TB will also be offered HIV counseling and testing services. But again, this is a new area and the challenges are there in its implementation. But it is policy for the time being in A and B category districts, and we will analyze whether the yield is sufficient enough to continue this policy and expand this in the low prevalence districts also.
So we have the last question for today's panel discussion. Why INH prophylaxis is not recommended by RNTCP to all HIV infected and affected children to prevent new TB cases? And if it is not being done, can we do it on a pilot basis?
It's a very good question. We are as concerned as you are, and I'm happy that people are asking this question from the field, because INH preventive therapy itself is a tool which is documented to reduce the TB infection. Basically, this is not being implemented only for operational reason. Policy guidelines have been approved, tools are ready. In fact, INH procurement is the barrier. When a tender was put up, we did not get any tender, but next time we got a bidder, but then he actually backtracked. Now we are having a mechanism whereby state can procure this from their resources that will be provided by NACO. But in these 30 sites, as Dr. Deshmukh said, innovative intensified case finding sites, IPT will be provided to begin with. But as a policy, this is to be provided across the country.
So with this question, we come to the end of this panel discussion. But before we depart, I will request Dr. Deshmukh to stress onto the key messages out of this panel discussion so that we can remember them and we can take actions on them. Dr. Deshmukh.
To summarize the entire discussion we had in the panel, first of all, basically why we had this forum with DAPCUs, because we had some feedback from different DAPCUs. There were some issues of knowledge gap. There were some issues of coordination which were evident in the field visits during the latest visit by the MM also, and before that also we had actually seen some of the aspects of coordination gaps at different levels in the district. So basically, in our discussion, there were many points which were emphasized, and the first thing is coordination. Coordination with the national health system, coordination with the revised national TB control program counterparts. Now we in India have more than 21 districts where the district TB officer and the district nodal officer for HIV are the same. So here there should not be any coordination gap, and DAPCUs can play a crucial role, critical role in bridging this gap if at all there are certain coordination gaps in this thing. TB HIV collaborative activities. Now, what important message I want to give through this that we need to coordinate down the line also. So we have seen that there are gaps in coordination with the block health officers at the block level. So basically, DAPCUs and can play an important role in also getting some feedback from block level also, and during their field visits they can also coordinate with the block health officers, because you see that in RNTCP block health officers are medical officer TB control in majority of the cases, and even for TB HIV collaborative activities we are involving them. Second most critical important thing is now the government has prioritized the testing, universal access to testing, and that's why we have to have testing, 100% testing for TB patients. Uh, and there the co-location is an important aspect, and in co-location you will see that DAPCUs can play an important role, as it came from our discussion, using the district authorities to actually embark on scaling up those activities. Third important point which sir came out of our discussion is the data. Now, the most important thing is data should be correct. If it is not correct at the district level, it will definitely reflect in the state level reports and the national level reports. So, data at the uh, district level should be validated. It should be correct, complete, and there actually DAPCUs can play an important role. Not only collecting the information but also seeing that how this information can be utilized for the program, and how best we can improve the quality of data which is there at the state level, district level. There actually we all are emphasizing that the monthly meetings of TB HIV are very good platform to exchange the data and see how the programs are moving ahead. And these meetings definitely add value in terms of update of knowledge. So you can see that there are a lot of programmatic changes in recent past which are changing the scenario. You will see that the rapid diagnostics are in place. You will see that drug resistant TB management is in place, and there are many new things coming up in the program, like the daily regimen. Many other things are there. Involvement of private sector, involvement of various healthcare providers, other sectors also in many of the districts, and there the regional coordinators of DAPCUs, they can actually play an important role also in coordination with DAPCO. Uh, then the important activity, what is the strength of DAPCUs is their communication strategy with the community. So advocacy, communication, and social mobilization for TB HIV activities. You will see that latest campaigns by Amitabh Bachchan are aired on the television. There are many creatives which are there in the program for TB HIV. These should reach to the intended audience, and there the DAPCO can play an important role. Already there is a lot of material, but it is not seen in the field. So there we can facilitate. Some of the very good practices, sir, we have seen that the APCOs were able to link the patients with various social welfare schemes, and that is very good practice we have seen in some of the states like Chhattisgarh, some of the states like Gujarat, where the social linkages are very good, and there DAPCUs have a strength. They can play an important role in linking these patients to various services. So some patients are getting benefits for transport, some patients are getting benefits through the pension schemes, some patients are now getting benefits through various corporate social responsibilities. So that can be actually a very good uh, linkage mechanism where DAPCUs can play an important role. In addition to that, what is most critical is the drug and logistic mechanism, as Dr. Revari sir has mentioned. CPT, though we say that it should be 100%, but then we are seeing that though the drugs are sometimes available, the patients are not getting it, or sometimes if the patients want it, there is a drug for a limited period. So basically, we need to look into these matters, because these are affecting the patient lives, and we'll have to see that the patient get the required drugs within the period of time, and then these should be actually validated through the field visits also. You are sending definitely reports to national level as well as state level on your field visit reports. So the qualitative report which mentions the details of the field visit should also incorporate the TB HIV findings in the field, whether the patient are taking the drugs properly or not, whether there are some loss to follow-ups, what can be done in those cases, and these type of feedbacks, qualitative feedback, which is very important for national level also, can be readily sent. One more important point which came in the discussion is the role of DAPCUs in training various level of staff. In that sense, actually, there are training mechanisms in place in RNTCP as well as NACP, but facilitation and seeing that which staff where needs sensitization training is an important thing, and that can be actually one of the important functions of DAPCUs. Uh, Even Dr. Revarik sir can also add a few things.
No, I think Dr. Deshmukh has covered most of the things. But my point is, as DEPCUs, you are supposed to supervise all the activities in the district. I'm not sure about the guidelines about what percentage of sites you are supposed to visit, physically visit, and how much is the coordination. Coordination is more in the office. What is the field visit? I think Dr. Govind will tell us more. We also have to see whether it is being done or not. That is another area. But my again request to you is that know your tools well. आपको मालूम होना चाहिए, you should know what are the M&D tools which are to be maintained at ART center, what is to be maintained at ICT. You may be knowing them, but you need to know them well and need to see whether one tool is connected to another or not. Person found positive at FICTC, DMC is linked to ICTC standalone or not, and once he is found positive, is linked to ART or not. If is linked to ART, his TB treatment has been started in time and ART has been initiated within the stipulated time and outcomes are recorded. So it's all a continuum. So whether this continuum is maintained and that you know your tools well, each indicator's definition. And once you know them, you have to train them to the field staff also. Programs are doing their job, ART is doing their job, ICTC, but you have to again see. Again, as Dr. Deshmukh was mentioning about social welfare schemes, I think you have got a very good strength in terms of care and support centers, which have got all the information about the social welfare schemes, and it is their responsibility. It is for HIV TB co-infected, but you can get that information for other TB patients also who are not HIV TB and basically pass it on to the TB staff also. Again, the utilization of outreach workers. Outreach workers have HIV program, outreach workers have TB program, whether they are being adequately utilized or not. So these are some of the thoughts that come to our mind that the DAPCUs will have a very important role. And basically, as you see, achieving this role, what is our aim is basically to achieve a TB-free India.
Thank you so much. With this, we come to the end of this panel discussion. I want to thank Dr. Iwari for his presence, Dr. Deshmukh for his elaboration on many things, and we also want to thank all the participants who could come and who can log in. And with the feedback from your side, we will try to do some more sessions like this in the coming future. So we'll await your feedback on this today's discussion. And with this, we end this discussion. Thank you so much. Have a great day. Thank you.
Thank you.
Thank you very much.